Okay.
So your paper...
Okay, let me share my screen for you guys.
Okay.
Ah, no. Okay, I have to... Where did it go?
Oh no. Freak out.
Okay, wait a second. Window. Okay, can anyone see my screen?
We can see your screen.
You can see? Okay.
Please start. Thank you.
Okay. So, okay. Thank you for letting me present. I'm very excited to present my research passion, which is studying lung cancer. My name is Kaitlyn Dunn. I'm a systems engineering PhD student at Florida Institute of Technology, and I work at the Mosaic Lab under Dr. Nezamodini Kachui, and we are a data analysis lab. And today I will be presenting my radiomics graph clustering for patient risk identification. So for my main outline, you guys can see my screen, right?
Yes.
Okay.
Yes, we can.
Okay, thank you. So for my main outline, I'm going to be going over the clinical problem that I'm going to be addressing, my data type that I'm using, my methodology, my results and impact, and then my final conclusion. So the main problem that I'm going to be addressing throughout this paper is lung cancer. Lung cancer is the leading cause of cancer deaths worldwide, responsible for about 1.8 million deaths in 2022. As you can see, tumor progression follows a nonlinear pathway that leads to biological heterogeneity and an unpredictable behavior, making survival risk approximation quite difficult to achieve. And this research finds that this unpredictable behavior of the disease encourages the need to understand the biological behavior and tumor progression, and then how that directly relates to patient survival outcomes. So the main clinical problem I'm going to be addressing is trying to find a way to capture patient risk. So current staging of lung cancer is done using an anatomical stage descriptor. You have stage 1, stage 2, stage 3, stage 4, and these are representative based off of tumor, node, and metastasis criteria. Stage where that is represented from stage 1, it is determined by how big the tumor is, and you get different degrees of stages based off of how large that tumor is. Nodal staging kind of goes along with whether that the anatomical placement of that tumor, if that tumor has gone into the lymphatic system, and that also is determined by how large the tumor itself is. And then a metastasis staging criteria can determine whether the tumor has taken over other organs. So an interesting aspect of this is that this anatomical stage representation you see on the right here, where we have stage 1, stage 2, stage 3A, stage 3B. These are the current staging criteria, which if you have a higher level stage, that should represent a lower survival or a bigger patient risk. However, when I have ran a Kaplan-Meier survival estimation on these on the staging that is represented within a lung cancer patient cohort, you can see that the actual tumor node metastasis, the anatomical staging has a very overlapping risk assessment, which kind of defeats the purpose of the clinical anatomical staging criteria. If we want to use this clinical anatomical staging criteria to evaluate the patient risk and later evaluate the treatment plan that that patient is going to have, you would like the actual stage assessment to represent patient survival risk appropriately so we can plan treatment plans better. So my main question is, why is the tumor node metastasis not fully representing the patient risk? And I wonder if radiomics, which is the data type that I will be using, can that help identify patients at similar risk groups to try and stratify patient survivability? So the current staging criteria that I've been talking about, TNM staging, is used to describe the anatomical extent, but this often fails to predict the biological aggressiveness, which would be present in a patient risk evaluation. So my data type that I'm using is called radiomics, and that this specific data set is extracted from CT images. And these radiomics can be used as a tool to actually describe the texture of the tumor, in which I think the texture could be used as an additional biomarker to evaluate patient risk to assist prognostic decisions for survival outcome measurements. So the data set that I have is a cohort of 398 patients, and these features are going to describe the tumor shape, such as having voxel volume, mesh volume, maximum 3D diameter, all of these shape descriptors and texture descriptors that wouldn't otherwise be evaluated using anatomical staging. So just a quick overview of what radiomics are and how they're extracted. They're taken from images of lung cancers, and these are typically on a CT scan. They are stacked, and using this stacked image technique, we're able to extract a two-dimensional pixel into a three-dimensional pixel with that is called a voxel. And these voxels can provide a volume and a thickness that can be converted into quantitative features such as surface area, diameter, and texture. And then we also have some shape descriptors, which is essentially the neighboring pixels surrounding each voxel, which can capture the tumor morphology and the microstructure, which can be used for our patient similarity measures. So the method that I'm using to create this patient risk evaluation is called a graft-based method. And the reason why I'm using this is because the graph-based method allows the patients to be represented as they are connected to each other. And this graph connectivity can be represented as whatever you define it as. In this case, I'm going to be representing the graph connectivity as a patient similarity. So instead of typically looking at a regular machine learning model, you would take all of these features that represent the shape descriptor, the texture, the size, etc. Those would be used in a typical machine learning model by comparing how those features differ across various patients. However, this specific architecture treats the individual patient as their respective tumor to try and find the tumor similarities that underline within this patient cohort. So in this representation, each of the patients are compared across each other by standardizing the features. So you standardize the features so they fall within the same scale. So we're able to evaluate what the entire tumor values are represented as for face value. And so we compare the features across each of the patients to kind of describe what that tumor will look like. And then once we have that feature standardization and we have a shape, and we have shape, pixel volumes, texture features that are represented for each patient, we want to find how related each of the patients are. And this is representing the patient in a radiomic space. So you look at each patient and you find the Euclidean distance between each of the patients to represent how closely related their tumors are based off of shape. Then that gets converted using a radial basis kernel to be represented as similarity. So when a patient is getting a similarity score of 0, that means that their tumors are not identical at all. And then when the patient gets scored with a similarity score of 1, it means it's the exact same tumor, just to put it in perspective. Then we use a survival aspect. And this survival aspect, one is another joint probability distribution that groups the patients based off of their risk categories. So the resulting adjacency matrix is a grouping system that groups the patients based off of how similar their tumor shapes are, based off entirely radiomics, and also how their survival plays into that patient tumor. So this is a very interesting way to represent the patients, because you can see that the patients see how their tumors change throughout different survival risk categories. So just to recap, we have our data input of 398 patients, and each of those 398 patients have the respective radiomic features that describe the shape of the tumor, and then also their respective survival times. And then using different kernels, we can convert those, we can relate the patients based off of the distances that they are from each other based off of similarity. And then the kernel converts that to a similarity basis. And then when you multiply those two together, the product is patients who are both radiologically and prognostically similar for this robust graph construction. Then we use a unsupervised clustering algorithm that can group the nearest patients depending on how similar they are. And then you can specify that for however many clusters you want, or however many nearest patients you would like to specify for any given cohort. So I'm going to share my results. So my results were that these patients were successfully grouped into what I like to call communities that represent the patients based off of similar morphological and survival patterns reflected within the tumor using a survival radiomic similarity adjacency matrix grouping. You can see how nicely separated each of these communities that were emerging completely independently of any survival measures besides the survival outcome censoring that I used. But it is very interesting as well because this is independent from any stage ordering. There was only radiomic features that were included, no features that actually said the stage of the patient or the age or demographics were included. So this was completely independent from any of those factors. So to do kind of an interpretability study, I have arranged these patients based off of their TNM stage by mapping their patient ID back to from the community to the stage at which those patients were diagnosed with. And as you can see, there's kind of a bit of mixing across all the TNM state anatomical staging, and then the communities that were identified based off of radiomic similarity and risk. And you can kind of see that there is a decrease in median survival as you go across the communities, which can represent a low risk community, a moderate risk community, a high risk community, and then the highest risk community. And then I also represented them based off of age to see if there was any overlap. And there is like clear separation among the groups, but there is no clear trend in there being age as an underlying factor for higher risk. You can see in this low risk category that there are a significant amount of younger people, but that is also reflected in our higher risk category too. So that leaves the question as what truly is driving the patient risk. So additional visualization here, we have you can really see like the risk categories that are emerging. It's interesting that our moderate risk category here is a majority of low stage. However, our lowest risk category here has only 0.8% of the lowest stage and 9.3% of our high stage, which doesn't really make that much sense. Why is that the case that these patients who live significantly longer than these patients, why were they diagnosed so frequently with stage 3? So that kind of suggests some staging limitations within the anatomical staging. So my clinical implications of this, this is a truly exploratory analysis to understand these patients' tumors and how the tumors may change throughout different risk categories, which reveals some very interesting insights regarding the current anatomical staging. It is interesting to just use radiomics to understand patient risk, and using just CT images, there may be better prognostic techniques that can be used using this risk evaluation. So here is the Kaplan-Meier survival analysis of the risk communities that I have identified compared to the Kaplan-Meier risk evaluation of the anatomical staging. And truly just more research needs to be done in evaluating these specific tumors and why they are having these respective risk groups, which could truly help assist this further Kaplan-Meier TNM staging representation. And hopefully it can create maybe personalized follow-up, treatment tailoring, and then patient stratification based off of these risk communities. So my main conclusions is that graph-based radiomic phenotyping uncovers survival risk groups that are not captured by TNM staging, driven largely by geometric tumor features. And then integrating these communities into clinical workflows could enhance personal risk assessment and inform further treatment decisions. Okay, thank you for listening. Do I have any questions from the audience?
Thank you so much, Kaitlyn. And if you have any questions, please fire away.
Hi, Kaitlyn. Thanks for the great presentation. I have one quick question.
Yes, of course.
You did the type of clustering here, is it correct?
Mm-hmm.
Oh, low risk, high. Then the technique you used was the K-means that?
Can you repeat that?
Was the K-mean clustering? Do you remember what technique?
It was spectral clustering with k-means.
So you need to tell that method we already have 4 groups, or no, it discover for you the number of groups. Group low risk, high, but you have 4 groups there. Right.
So I did have those groups that were emerging. However, you can specify however many clusters that you want to observe based off of modularity scores and silhouette scores and David-Bolden indexes. You can find which sort of grouping has the best metrics.
No, thank you.
Of course, thank you.
All right. I might have one question. Did you do any evaluation against other methods?
Chica.
So, are you referring to unsupervised clustering methods?
No, current methodology.
Okay. I think I understand your question. So the different measurement, so the way that I approximated the distance could be altered. I did use a Euclidean distance approximation. However, I could use some alternative, more sophisticated techniques such as Mahalanobis or even Manhattan distancing or cosine approximation. But I chose Euclidean because it is the simplest.
Great work. And I can see you're presenting another paper too. Is that correct?
I am.
So the next paper is going to be RPSGNN, radiomic patient similarity graph neural networks for lung cancer stage classification. By Kaitlyn Dunn. Please go ahead. Thank you.
Let me stop share. No share. Wait, you need to sit closer. Okay, there we go.
This is Dr. Kachi's son.
No. Yeah, we're on the wrong slide. Okay, can everyone see our screen?
We're still muted.
Yes, we can.
Okay. We're not moved. Okay. So, again, I will present a second paper that I have